So this was the approach. We were discussing that still the incidence of the hypertensive disorders of the pregnancy is 10 to 11%. And we said that still the number of eclampsia is there in India. And if we give some approach towards tackling this dreadful condition, definitely we can prevent it and we can make it zero. And that's why we have taken this mission that by December 2025, we have a lot of time. I will say we have 1.5 years. So those ladies who want to become pregnant, those who are pregnant, definitely we have a long distance of 1.5 year, and definitely we can do a lot of things in this. This approach is Glacamagar. So I was fortunate to prepare this. We start with the universal screening. We all know that there are n number of tests which are available for the prediction. Some say use Doppler, some say use biomarkers, while the Western papers now they are saying that do the combined approach and use biomarkers along with Doppler and along with maternal factors. And through the paper of Spree, they have shown the detection rate by using the combined approach of maternal factor plus biomarkers plus Doppler in case of early preeclampsia. But when practically, if we see this, number one, this was not a proper study, this was a regression analysis. Number two, if we see the guidelines of whole world, let us start from a NICE guidelines, American guidelines, Australian guidelines, WHO guidelines, our own Gestosis, ICOG, FOXY guidelines. None of the guideline has mentioned that this should be done as on primary basis. The reason behind is the cost factor. Because if we want to prevent some disease, we have to do the universal screening. And if we see the definition of universal screening, it has to be simple, easily reproducible, can be applied to all population easily, and it should be cost effective. If we do the screening by that combined approach, total cost may go up to 3,000 crores per month, which is not a big cost. I always mention that when I checked the website of National Health Mission, this 3,000 crore will be the 1/10 of the total allocation, which is not possible. And that's why even American guidelines, they have mentioned that the clinical risk factor based screening should be done. In their guideline, they have given 15 factors. If you see the NICE guidelines, they have given 12 factors. If you see the WHO guideline, they are also saying that this screening based on clinical risk factors, maternal factors must be done. Now coming to our HDP Gestosis score. When all these discussions were going on 3-4 years before, since before Corona, we all came together and I initiated this work, and then I came out with a simple dynamic quantification of the maternal clinical risk factors, and we quantified it, and this is how came the HDP Gestosis score. There are 27 factors. Everybody know there are so many presentations right from Jammu to Kanyakumari and Ahmedabad to Kolkata. There are almost 64 theses and almost 10 to 12 national and international papers have been written on this HDP Gestosis score. This is a validated score. The first and foremost thing, it's very easy. Second, zero cost. Third, can be done by even our ANM, our GNM, our any resident, and we all can do it very easily. Initially, we distributed some one A4 size format, but nowadays, even it is available free of cost as a Android application. If you go on the Android App Store and if you put HDP Gestosis score, then it's a free of cost. We can download it and we don't have to put many data, and automatically when we put our email id, all data comes to your email id, the person who is doing that justice score. So automatically you can gather information of your institute as well. Out of the 27 factors, there are 22 factors which are simple history taking factors. When I always say there are persons, senior persons like Sharda madam is here, Ragini madam is here, who has taught us that whenever any patient comes in front of us, we have to have a good discussion with her. We should take a good history, clinical history. And all these are the routine factors. So if we ask them, even at the first visit, we can be aware that, oh, this lady has so many risk factors from history only. And we have to do the quantification. There are certain factors which are called as mild risk factors, and they are quantified as 1. So only single factor is present, nothing to worry. We have to see whether other factors are present. So if say, for example, there are more than 3 mild factors are present, so the total risk becomes 1 plus 1 plus 1 is equal to 3. And we have mentioned that when the HDB Gestosis score is more than or equal to 3, the patient is to be labeled as that she is at risk to develop preeclampsia. Now I will give the example. Number 1, primigravida. Then if she is obese, say more than 30 BMI, and she is a classic case of PCOS, so that means she is primi, then PCOS, and then obese. So all these factors, when they are combined together, the risk is there. Then some of you might say that, "Arey, हमारे तो सब पेशेंट इसमें आ जाएंगे." So does it happen? Answer is no. We have found out through more than 60 papers that the sensitivity and the specificity and even the negative predictive value is absolutely good. Sensitivity and specificity more than 90% is reported in almost all papers. Then somebody said whether your methodology of calculating this score is right or wrong. A beautiful study was done at Symbiosis, and then they applied the artificial intelligence AI technologies, and they compared it with the Gestosis score methodology and came with the conclusion. Recently international paper has been presented, and they mentioned that yes, the methodology of calculating the Gestosis score is simple, scientific. It is a validated score. Another beauty of this score is it is dynamic. Means, see, if we compare the other methodologies of screening for the preeclampsia, say for example, doing or doing the Doppler. I am not against at all about these things. I am very much concerned about its applicability, about its cost for my each and every pregnant women, which is not possible, and that's why we are against it. Another thing is these things they are been said that they are to be these methodologies are to be applied for the screening at 13 to 14 weeks. Is it right? The answer is no, because we all know the cause of these hypertensive disorders of pregnancy is the defective trophoblastic invasion. The first and second trophoblastic invasion waves they complete almost at 12 weeks. पहली और दूसरी दोनों waves they are being almost completed. So whatever the thing are to be जो होना चाहिए था वो हो गया है already. And then what is the meaning to do the screening at 13 to 14 weeks and that too only at one time? The beauty of the Gestosis score is that there are five factors which are dynamic. Example, anemia. Second, hypothyroidism. Third, the GDM. Fourth, the weight gain. And five is the mean arterial pressure. And if you realize all of these five things we are doing almost at every visit, though not every visit, the CBC, TSH, and GCT, that is glucose challenge test, it has been advised to do in each trimester. So that means there is no added cost to the patient. And at each visit, suppose, example I will give you. Initially, the Gestosis score was 2, and we find that at 15 or 16 weeks, we have done that GCT, and that has come high, and she has been now detected as a GDM. So now the risk factor of by Gestosis score, it becomes 4 because the initial score was 2 and now she is being detected as a GDM. So it becomes 4. That means she is at risk to develop preeclampsia. So right then and then onwards, we can start the preventive methodology and definitely we can minimize the incidence of preeclampsia. And once we minimize the incidence of preeclampsia, once we minimize the severity of preeclampsia, from where the eclampsia will come and from where the mortality and morbidity out of the eclampsia will come. So coming to the prevention. Again, in prevention, very simple 3 things are there. And most of us, they are doing it, but we are little confused. What are those confusions? Through many conferences, through many of the activists, we hear कि ये इस टाइम से शुरू करना है, उस टाइम से शुरू करना है. No, please, simple thing ध्यान में रखना है, low carbohydrates. Now, the Tata Institute of Cancer, they have come up with a beautiful article, sugar is next tobacco. So, सब लोगों को हमें पता है, our Indian women, they are at 11 to 12 times high risk to get metabolic syndrome, and it is again our diet pattern, our high carb and low protein diet pattern that is responsible. And now, through all the papers, it has been proved that if we shift to the low carbohydrate diet, definitely all these risks they go down. So no added sugars, low carbs and high proteins is the first preventive strategy. Second is aspirin. We all know that acetyl salicylic acid or aspirin, if it is taken at bedtime daily from the point where the lady has been assigned that, oh, she is at risk to develop preeclampsia till delivery, or we can say 2 days prior delivery or 48 hours prior delivery or induction, if the aspirin is given, definitely it has been proven that the incidence of preeclampsia has gone down. Now coming to the dose of aspirin, there are so many confusions. But again, I want to tell you, there is no confusion at all. See, what is the why? What is the dose? What is the mechanism of action of aspirin? Just to balance between thromboxane A2 and PGI2. And what is the minimum sufficient dose for this balancing between the thromboxane A2 and PGI2? We all know the man who has more than 100 papers and almost all guidelines are based on his papers, Baha M. Sibai. He has clear-cut mentioned that 40 to 60 milligram of the aspirin is required to balance this. In fact, so many researchers, they have also given a second thought to it and they have said that if the dose is increased, say more than 100, then there are chances that this balance may alter. Second thing, the aspirate trial, that has stirred a lot. That has stirred a lot. There they have done the comparison of 150 milligram of the aspirin with placebo. Why they have not done with 75? There is no single paper available which has shown that this 75 has a less response and 150 has shown something great. It was a comparison of placebo, and that too, only some 850 patients were seen, though they are showing that okay, 25,000 of the women they were screened and etc. The study population is 850, and out of them, almost more than 20 to 30% of the patients they were chronic hypertensive. So with only one paper, how we can change the guideline? And at the end of paper, they have mentioned that the 150 milligram safety for the neonates, we have not given much attention. So that is a very dangerous thing. WHO has intervened so, and in 2023, they have clear cut given a white paper that till further studies, the dose for the prevention of the preeclampsia of the aspirin should be 75 milligram at bedtime. So there is very clear cut message that aspirin 75 milligram at bedtime from the day when we have attributed the risk to that pregnant lady that she is at risk to preeclampsia. Then somebody will say ki, Are, suppose we have calculated the Gestosis score at 7th week, 6th week, 8th week. Should we start aspirin right from there? Yes, because then and then only we are going to prevent the preeclampsia. Because again, coming back to that line, the defective trophoblastic invasion, first wave is at 6 to 8 weeks, second wave is completed near 12 to 14 weeks. So whatever prevention we have to start as early as possible. All my IVF colleagues, seniors, those who are practicing in severe other medical morbidities with pregnancy, they will agree that we are starting aspirin right from before conception in many cases. Is there any problem? No. Third thing is calcium. Many a times we prescribe 225 ka capsule. We prescribe कि patient नहीं खाएगा बड़ी capsule है etc. Forget about it. 1 gram calcium has to be given the day we attribute the risk to that pregnant lady about the HDP. 1 gram, 500 milligram in 500 gram, 500 milligram in the morning, 500 milligram in the evening. We can distribute it so that again somebody will say WHO has mentioned that it should be given in the low resource of calcium. Do we agree that all our Indian population is daily taking 1 or 2 glass of milk? They are taking 2 or 3 eggs daily? No. Then simple thing. Whenever we are saying that this lady has risk to develop preeclampsia, start calcium, 1 gram elemental calcium. That is very important. सिर्फ वो 1 ग्राम की गोली नहीं होनी चाहिए. It has to be 1 gram elemental calcium. कई कई गोलियों पे लिखा है कि 1250 कैल्शियम और आगे लिखा है एलिमेंटल कैल्शियम इज इक्वल टू 500. सो दैट मीन्स ऐसे हमें 2 देनी पड़ेगी. सो वी हैव टू चूज a good combination or a good dawa जो भी है वो. So when we come to the prevention, it is low carbohydrate diet, 75 milligram aspirin, 1 gram calcium, and definitely we can reduce the incidence of preeclampsia. Now चलो इसमें से कोई पेशेंट छूट गए या जो the patients we have not been screened, they come in our OPD and we find that oh, they are hypertensive. Then the question comes, when to start the antihypertensive and what should be the drug until how to continue and etc. Simple thing we have to keep in mind. Now all the guidelines, they have come to the conclusion that the baseline blood pressure, if it is more than 135/85, alarm should come in our mind that oh, she or me, they are at risk to develop blood pressure. Days have gone when we were discussing it is mild, moderate, severe. Forget about it. Once we use the word mild, our approach also becomes mild. So Gestosis India has coined simple thing. It is a severe preeclampsia. That's it, which should not be mild or moderate. When it comes to the hypertension, when the level of 140 by 90 millimeters of mercury is crossed, we have to start antihypertensive. Days have gone. Somebody will say कि हमारे मैडम हमारे यूनिट में हमारे सर हमारे यूनिट में ऐसे किया करते थे. Days have gone. Clear message. 140/90, we have to start antihypertensive. Clear. Which antihypertensive? Simple, there are only two tablets. Forget about alpha dopa. Days have gone. There is no alpha dopa. Forget. Only for two things. One is nifedipine and another is labetalol. Now, what is best? Both are best. We have to choose the antihypertensive जो आपको feasible है. And if the baseline pulse rate of the patient is more than 100, automatically I will choose for labetalol. If it is less than 100, I will choose the nifedipine. If suppose the patient has history of asthma, I will not go for labetalol. So depending upon the contraindications for that specific drug, availability of that drug, condition of that drug, a patient. If the patient has, we know, middle branch blocks hai, heart blocks hai, etc., we cannot use labetalol. So all these things we have to keep in mind. But otherwise, these two medicines, labetalol or nifedipine. If we use labetalol, the dose is 100 milligram BD. We have to start. Don't start with half BD, half OD. It is not the dose. The dose is 100 milligram BD. That is the initial dose, and the total dose in pharmacology given is 2,400 milligram. But we do not go up to that. Ideally, it is mentioned that till 800 milligram definitely we can increase. And if the total dose of the 800 milligram is been crossed, we have to add second antihypertensive. Second thing, we have to see the pulse as well of the patient, and depending upon, we have to titrate the dose. We are talking of mild hypertension. If it is a patient of severe hypertension, definitely it is IV labetalol. And we all know it is 20, 20, 40, 40, 80. 80, and I always say उसके बाद भगवान का फोटो, बाकी तो कुछ है नहीं. क्योंकि if we cross 300 milligram of labetalol total IV, then it is really a risky case. But there are very few cases of such hypertensive emergencies. We are not talking about them today. But simply, we have to start antihypertensive at 140/90 is a message. Few lines about nifedipine. Nifedipine is available in three forms. One is capsule, another is plain tablet, another is slow releasing tablet. Discard the capsule dipines from our practice. So we should not use sublingually at all, because our patients, the baby is still inside the womb. They are at risk to develop myocardial infarction as well as placental abruption. So no sublingual dipine. In fact, in the presentations of Gestosis India, we have added a line that using sublingual dipine, nifedipine, is a crime because it is really risky. So that has been gone. Now only two things are available. One is plain tablet, another is SR tablet. So when we want to do the control of mild hypertension, SR tablet. If we want a control of severe hypertension and we cannot use labetalol, plain tablet. Because it is a very simple thing we have to keep in mind. Now, in case of severe hypertension, we all know, I'm not going in details, but we should know that total 60 milligram of the nifedipine can be used by 20, 20, 20, 20 at the interval of 15 minutes, etc. I will not go in details. One line message, antihypertensive at 140/90, either nifedipine or labetalol tablet. Now the patient has come in front of us with severe hypertension or severe preeclampsia. How we define severe preeclampsia? There are two definitions. One definition, the blood pressure more than 160 by 110, and whatever may be the lab condition, maybe the lab may be normal, but the blood pressure readings are 160, 110 or above. That is a case of severe preeclampsia. Second definition, whatever may be the blood pressure, but patient has either premonitory sign symptoms or the lab parameters are abnormal. That means, suppose the patient has blood pressure 140/90, but it is showing that her lab parameters have gone haywire. She is severe preeclampsia. Or even her blood pressure is 140/90, but she is showing all premonitory signs and symptoms about the severe preeclampsia. She is again severe preeclampsia. So in all such patients, we have to timely institute magnesium sulfate. And this is ग्लैकम एगर में से जी हो गया, एल हो गया, ए हो गया, सी हो गया, ए हो गया, and now this is mag, and mag is MagSulf. So magnesium sulfate, I always say it is a Sanjeevani booty. So minimum 20, those who are practicing obstetrics, minimum 20 to 25 magnesium sulfate ampules of 50% weight by volume. That means 2 ml का ऐसा मैक्सल्फ का एम्प्यूल जिसमें 1 ग्राम मैग्नीशियम सल्फेट हो, वो हमारे वो लेबर रूम में होना ही चाहिए. Minimum 25. Otherwise, we are not entitled to do the obstetric practice. It's very clear. It's a license. Now, if we give magnesium sulfate to all...
Sir, this requires repetition by you. So
Yes.
everybody listens.
Yes. I will repeat it. There are 2 types of magnesium sulfate ampules. One is 25% weight by volume. Another is 50% weight by volume. So please discard all those ampules who are having 25% weight by volume, because they will create more confusion. Simple idea. Always we have to keep the ampule which is 50% weight by volume 2 ml. That means each ampule contains 1 gram magnesium sulfate. And minimum अगर हमारे ओटी में, हमारे लेबर रूम में 25 मैग्नीशियम सल्फेट के एम्प्यूल नहीं है, हमें ऑब्स्टेट्रिक प्रैक्टिस नहीं करनी चाहिए. That is the clear message. And then only we can go to the mission of zero eclampsia. Because here we are talking that magnesium sulfate for prevention of eclampsia. Now question comes, which regime to use? Duspan or Pritchard? Again, please do not confuse. Think, if you have all facilities of injection pumps, of so many monitors, of so many residents who can monitor all these things, you can use the span regime. But I don't think such setups will be 1 or 2% remaining at all centers. And that's why our own Indian government has given us a very good approach that please use Pritchard. And in that again, what is that Pritchard regime? Simple. 5 gram means 5 एम्प्यूल ले लो, 10 ml सिरिंज में ले लो, उसमें 0.5 ml का 2% झाइलोकेन ऐड करो एंड गिव इट डीप इंट्रामस्कुलर. एक बटक में, दूसरा भी वैसे ही दूसरे बटक में. So total 10 gram magnesium sulfate in divided 5 gram in each buttock with 0.5 ml of 2% xylocaine we have given, then definitely it is going to reduce the incidence of eclampsia. And where the facilities are available, we have to add the 4 gram IV dose as well. There are so many questions, worries in our mind. Jare maximum diya to it causes that and it causes... No, never. How we give it, depending upon that, there are complications. We should not use the jet pump. How to prepare that 4 gram IV wala? Simple idea. Take a 20 ml का syringe. Take 4 gram. That means हो गया 8 ml. और बाकी का 12 ml नॉर्मल सलाइन ले लो, तो हो गया 20 ml. So 20 ml over the period of 5 to 10 minutes we have to give. It should not be a jet. A simple idea. 4 ml 1 मिनट पे दे दो तो ऑटोमेटिक 5 मिनट पे चला गया. It will not cause any problem. And to give this is, we call it as a loading dose. जब ये loading dose देते हैं, there is no necessity of any investigation. when patient comes in front of us with severe preeclampsia, we have to give this loading dose, and then antihypertensives to be given. And the last approach of glycomagar is early referral. We have to do the early referral at the higher center. Purposefully, I have not mentioned here tertiary, quaternary, etc. If you are able to manage it, please manage. If you are not able to manage it, should we ideally send that patient to the tertiary or quaternary center? And how to do that early referral? Number one, patient is in front of you with severe preeclampsia. Please make her calm. Discuss with her. Discuss with the relatives. Give her magnesium sulfate loading dose. Make her calm. Put two IV lines. Give her antihypertensive. Make her calm. Discuss with her. Give a good referral sheet to her. And wherever you are referring, please call that person and inform him, this patient I am referring to you. I have given this much medicines and I am sending it to you for so many these things. That's it. छोटे छोटे कामों के लिए हम ये व्हाट्सएप का यूज करते हैं. Why cannot we use for referral? Because most of the times इंडियन गवर्नमेंट को गाइडलाइन बनाना पड़ा कि कैसे रेफरल करें. That was a poverty in our fraternity about the referral, कि रेफरल किस तरह से किया जाए. पेशेंट का नाम, उसका क्या डायग्नोसिस है, उसे हमने क्या क्या दिया है, व्हाट इज अवर क्लिनिकल डायग्नोसिस, और जो जो इन्वेस्टिगेशन है वो सभी एक साथ अगर हमने उसको एक पूरा पर्चा बना के दे दिया, आई डोंट थिंक देयर विल बी एनी कॉम्प्लिकेशन henceforth in our total fraternity. So this is a Gorakh approach. So I repeat, universal screening by Gestosis score, which is a cost effective 0 rupees का score. Prevention, low carbohydrates, पेशेंट से हमें बात करनी है क्या खाना है क्या नहीं खाना है. एस्पिरिन 75 मिलीग्राम. रिमूव द कंफ्यूजन. फिटल मेडिसिन वाले बोलते ये बोलता वो, फॉरगेट अबाउट इट. एस्पिरिन 75 मिलीग्राम एट बेड टाइम एज अर्ली एज पॉसिबल टिल. कोई बोलेगा सर अगर थ्रेटन एबॉर्शन हो जाता है, थोड़ा सा ब्लीडिंग हो जाता है, फॉरगेट अबाउट इट, कुछ नहीं होगा. प्लीज चेक प्लेटलेट काउंट, प्लीज चेक प्रोथ्रोम्बिन टाइम. आराम से यू कैन कंटिन्यू. Calcium 1 gram, it has to be elemental calcium. Early antihypertensive at 140/90, either nifedipine or labetalol. No capsule nifedipine, tablet labetalol. That too for mild SR tablet. How to choose antihypertensive? Depending upon the pulse of patient. Magnesium sulfate, Pritchard regime. Loading dose for all severe preeclampsias. And early, proper, descriptive refer to the higher centers, and I am damn sure that this mission ZEC 2025, zero eclampsia by 2025, is it possible? Yes, it is possible. So I am very much thankful to all of you, especially Dr. Sharda Jain madam. मैडम आप इतने सीनियर हो, स्टिल यू आर वर्किंग लाइक एनीथिंग. मैंने आपकी एनर्जी देख के आई ऑल्सो गेट कि अरे कितना काम करना चाहिए. एंड यू आर स्प्रेडिंग ऑल दिस मैसेजेस अक्रॉस द कंट्री. आपने जो जो मैसेज डाला है उसे जिस प्रकार से रिस्पॉन्सेस मिल रहे हैं, ओवरवेल्म्ड, ऑलवेज देयर फॉर दिस, क्योंकि आवर मिशन इज नॉट अ सिंगल मदर शुड डाई. इफ वी कीप दैट मोटो इन आवर माइंड, डेफिनेटली वी कैन अचीव दिस मिशन. आई एम थैंकफुल to Dr. Vandana ji. Since almost 6 months, madam is behind me, and she always out of her schedule, she always tells me अरे आपका इतने बजे लेक्चर है, लिंक भेजना, सब चीज़ें करती है मैडम. आई एम वेरी मच थैंकफुल टू यू, एंड आई एम थैंकफुल टू हरियाणा एंड ऑल यूर सोसाइटीज. yesterday I was in चंडीगढ़, आज ही मैं आया, कल शाम को ही आया. So I was there for different mission, but I'm thankful to all of you as well for giving me this opportunity and listening me carefully. Thank you very much.